health systems need to take the lead in developing a better presence in some of these underserved communities.
Welcome to Talking About Kids. I'm your host, R. Bradley Snyder, researcher, activist, and author of The 5 Simple Truths of Raising Kids. My guest this episode is Timothy McKnight, a respected pediatrician, a second-generation Black physician, and an innovative leader. Tim believes that more can be done to address the healthcare disparities that too many families face, and he believes that pediatricians are in a unique position to help bring about those necessary changes. It is why he teaches leadership skills to pediatricians and why he is the director of a program that supports students from communities that face healthcare disparities on their paths to becoming physicians. Tim and I discuss his inspirational work as well as what you can do to help end healthcare disparities. This episode is sponsored in part by the Arizona Department of Health Services Must Stop Bullying campaign through its Title V Maternal and Child Health Program. For more information, go to muststopbullying.org. Talking About Kids is designed to help parents, teachers, and other professionals help kids. If you are enjoying the series or this episode, please consider giving it a positive review and sharing it with your friends and colleagues. And now, the interview.
I'm the youngest of 9 children. I come from a very high, overachieving family, and I am the 4th physician in the family. Okay.
Wow.
So I have 2 older siblings that are doctors, but most importantly, my influence in medicine came from my father. Okay. And his period in medicine was completely different from what I went through in the 80s, given the fact that he graduated from medical school in 1945.
Wow.
A much different time for the Black physician in America. It was a time in which they had to refer patients to themselves to essentially provide for their families and put food on the table. They weren't allowed to touch white patients. They could not get privileges at major hospitals throughout the United States. And some of that started to change in the mid to late 60s. And my father was second and third Black physician on staff at some hospitals in Washington, D.C. So my interest, to answer your question, in medicine really developed and was born out of just watching my father, okay? Going on house calls with my father in the 60s in some of the roughest neighborhoods in Washington, D.C.
Right. And just, it's probably obvious just from your description there, but what do you want listeners to understand about what you learned from those experiences? So you're going on these house calls, you're going into these underserved communities, and what did it teach you?
Well, it really dates back to knowing that the underserved is an at-risk population. They're worried about their day-to-day survival. They're in survival mode. So they're not always compliant with their medications. And certainly during that period in time, healthy lifestyle was not really a thing, right? People were smoking cigarettes. And, my father smoked Pall Mall cigarettes with no filters, okay? So it was a different landscape. And I truly learned the value of compassion, the value of treating people fairly, And my father, back then it was fee for service. So he if he didn't have money to pay or what have you, he'd take a pie, he'd take anything, right?
Mm,
And so, it was a different style of medicine back in that day, where the technology wasn't where it is today. And as my father used to tell me, medicine is more of an art than a science.
mm,
So you had to rely on your hands,
mm,
right? Your history taking. You had to rely on your ability to become a better diagnostician with your hands.
mm.
And so to me, that was kind of like, wow, kind of like the golden ages of medicine in some ways. Even though we've come a long way in terms of our medical advances, granted, I
Right.
don't want to take that off the table. But just being a pure diagnostician with your hands, it's kind of a lost art.
Right.
Yeah.
Well, but there's a couple of things I want to say about that because I know a little bit about your career in your history. And one of the things that you advocate for, and correct me if I'm wrong, is that you believe that pediatricians need to kind of step up and assume more leadership roles in their communities. And
Hmm.
am I stating that correct?
No, you're correct. I mean,
Yeah.
and it's a very weird position to be in, right? So and I counsel a lot of doctors in terms of making that transition from a clinical career to a non-clinical health
Right.
career, right? And there are many avenues you can take, from pharmacy to academia to research to consulting, managed care, advisory work. The list goes on. I was in corporate America for a number of years in the payment accuracy claims correction space, a very narrow niche in
Mm,
the non-clinical health career. And what I found is you're kind of typecast as a pediatrician.
mm.
So as I was talking to recruiters, they thought I couldn't think about adult problems because I was a pediatrician, right? So basically, I had to do a lot of education and teaching and let people know that, pediatricians who take care of kids are just taking care of smaller adults for the most part. And my most famous line to the not so smart but arrogant recruiter is, good leadership does not have a specialty.
Mm.
All right. And so people have learned over the years that when I'm taken out of a job situation, that service line will suffer. That program that I've built will not be the same.
Mm.
And who is driving the bus at the very top makes a big difference.
I guess what led me from your story of your experience with your father to the question I asked there is that I have to imagine, and look, I'm not a physician, but I have to imagine that in order to diagnose using your hands and less sophisticated tools, whatever is available to you in that moment with that person, that it requires perhaps a deeper understanding of that patient as an individual.
Well said.
And
And so people equate pediatricians to being veterinarians
mm,
because a patient can't talk to you. A baby can't communicate with you, right? A baby's not
oh,
a 2 month old, a 3 month old, a 6 month old. It's
right,
not going to look at you and say, "Hey, Doctor Tim, I've got meningitis. Hey, Doctor Tim, I've got an ear
right.
infection. Hey, Doctor Tim, I've got a pneumonia." So you've got to ask the right questions and do a good exam. And have I found things on pediatric patients that adult doctors in emergency rooms have missed? Oh, all the time.
Mm,
Yeah. A diaphragmatic hernia,
mm,
where part of the intestines is going up into the lung in a newborn. Yeah, I found that because the emergency room doctor didn't do a good exam, didn't ask the right questions. So yeah, we wear a different detective hat because sometimes the patient cannot tell you what's wrong. And you have to rely on the parents to get the right history.
And this leads to, and again, to two of your passions. And
Hmm.
I'm going to try to address them separately, but even though I know that they're terribly and necessarily intertwined. But I have to imagine then that when you're talking about pediatricians becoming leaders in their communities, it's because there are things that they know about the communities that they're serving that other adults and other professionals in that community don't know. Am I right about that as well?
Well, I'll tell you that after 20 plus years of being a pediatric hospitalist,
Mm,
taking care of sick kids in a hospital, I have watched 4 hospitals in Northeast Ohio close since the 90s. I have watched countless number of pediatric units close. And part of it is pediatrics is season, there's a seasonality to it where they're very sick in the wintertime,
yeah,
early spring, summer, it's a little different disease process where kids are having different issues that might be more trauma related because they're outside playing. But the value proposition I would give senior leadership was for most families, the mother is making the healthcare decision in
mhm,
the house. And if they see your child being taken care of in a hospital ward, in a community based hospital, and that care is rendered at a 5-star level, there's a chance that entire family might come to the hospital. So this was my argument for those
mm,
at senior leadership about do we keep this pediatric ward open or not, right? And I distinctly had the pleasure of developing a pediatric hospital service over 8 years and handing it off to a health system in 2015. And sadly enough, Bradley, the health system was not able to sustain that pediatric unit, and that unit closed 2 months ago. So it's just amazing that it's got to be the right person at the right time that can be out there making the contacts, a grassroots approach to getting pediatric
right.
patients referred into the hospital, but most importantly, really making the case that pediatrics is important for there to be a full service hospital in that community.
But I also think, Tim, that especially children, and especially children interacting with healthcare providers, are kind of barometers for what's happening in a community,
Hmm.
for what's happening. Like it, I again, I'm not a pediatrician, but I've investigated schools and I've investigated juvenile prisons. And if I really want to know what's going on, I go through medical records because the healthcare providers stand outside the system. They typically answer to, well, to their own morality, but also to licensing that is independent of school administration or prison administration or detention center.
Hmm.
And you can look at the medical records and get a closer sense of the truth of what's happening in an institution. And I suspect that's true also for like communities and neighborhoods.
Yeah, and there are trends in healthcare, uh, especially as it relates to infectious disease, but also certain behaviors that
Yeah,
might be trending in a particular part of a city versus another. Absolutely. And the tricky part about my job was really developing rapport with the parent.
right.
And a lot of folks were like, "Well, why would you go into pediatrics? My God, aren't those parents a pain in the you know what?" And I quite frankly was blessed not to have an issue with the parent. And not only did I work as a pediatric hospitalist taking care of kids in the hospital, but I worked in a pediatric urgent care that was within the emergency room every Thursday for over 15 years. And some parents would wait until Thursday because they knew I was in the emergency room that
Yeah.
day to bring their sick kid in, right? So you develop a little bit of a rapport, a little bit of a following once you're able to connect with people out in the community.
that
Now, the underserved piece is even more interesting
right.
because, like I said, a lot of hospitals aren't able to sustain a pediatric unit, and so where do these kids go? Is there an access issue? And how can we get better to serve the underserved? And federally qualified health centers do play a role in this, but even then, a lot of those doctors tend to be family practice, not pediatrician doctors, and so there's a dynamic there as well.
Except for, I mean, there. If I can just editorialize here for a moment, w- every bit of scientific research that we have about both health and mental health is increasingly indicating that the early signs of every condition that we're concerned about, whether or not it's depression or heart disease, manifest earlier than we thought. Right. So we know if somebody is going to develop heart disease, sometimes as early as, early childhood. Right. So
Hmm.
the notion that we get rid of pediatric care just means that we're going to have bigger problems when we see them as adults.
Well, obesity within itself is a big driver behind some of these other chronic illnesses that show up later on,
Right.
right? So obesity is the huge driver behind developing hypertension, diabetes, heart disease as an adult, and we're certainly failing on that end, right? We've become a very fast-paced society. We've become a very not so well.
Hmm.
There's a lot of food deserts out there,
Yeah.
okay,
Right.
and a lot of food deserts in underserved communities. So I can't blame the communities themselves, but the sad part is we have to get better at getting rid of some of these social determinants of health and helping these communities thrive and live healthier lives and getting rid of some of these food deserts that exist in so many parts of urban communities throughout the country.
Yeah.
So it's really a beautiful blend of health, social, public health, all wrapped up into one in terms of peeling a very complicated onion, right?
Oh yeah.
And there's no one size fits all solution.
Well, but, I mean, you are making some very specific recommendations, and you are driving one avenue of change with some of your advocacy. And I want to get to that, but first, I also want to talk about this other thing. You talked about how hard it is to get parents to trust you, and especially parents that are coming from underserved community. There's a history to that, right, Tim? There's a reason why certain populations aren't going to trust our healthcare providers.
Oh, you're going to get my heart rate up, but you're so correct. And you know the history behind this is really troublesome
Mm,
and at the same time very complicated. And a lot of Black and Brown communities have a mistrust for healthcare. There's a lot of things that have gone wrong where uh, you know African American patients were enrolled in studies and not told they were being exposed to different disease entities and didn't receive proper care, proper treatment. People died, and it actually led to the development of you know, institutional review boards and
mhm,
more what I call more fair treatment for subjects that are being involved with research. And
mhm,
I'm actually referring to the Tuskegee syphilis
mhm.
treatment studies done back in the day. But so there's a big gap we have to kind of bridge here, and it's not a one and done thing, right? It's about building out a relationship in these communities to get this trust back. And I serve on a lot of nonprofit boards that are trying to do some type of services and more underserved communities as it relates to cancer care FQ8C work and things of that nature. And they'll look you right in the eye and say, this can't be a one and done, or it's
Right.
just not going to happen. Right. And so, I hired a community outreach coordinator who is very active in the community and building out those K through 12 relationships and helping kids get excited about science and healthcare. And our goal is to try and get more Black and brown folks to think about medicine as a long-term career.
Well, and before I get to that, because I absolutely want to talk about your Pathways to Practice program.
Hmm.
Um, but I have to imagine. I was just thinking about the Tuskegee syphilis studies and the Belmont report in preparing to talk to you today. And my own experience working with some of the populations that I know that you're passionate about. I don't hear people talking necessarily about the Tuskegee study as the reason they don't trust um, healthcare and mental health care providers. It seems like it's morphed into something else. So, for my teachers and my direct service providers who are listening, it how are they going to see that history? What sort of words and phrases or attitudes can they expect from populations? In particular, I'm talking about Black populations and other populations adjacent that were affected by something like Tuskegee. But that's just one incident of a larger problem. And so,
Hmm.
what are they going to hear from patients, or what are they going to hear from communities? What sort of prejudice against mental health and healthcare providers are they going to hear so that they can maybe anticipate this?
Well, wow, health systems, I think, need to take a certain role in this
Right.
in terms of having a more of a presence in some of these communities. And so I've seen some of the health systems buy out urban hospitals and close them.
Mm,
In one particular instance, they took the hospital and turned it into a community, into a health center. Right, more in line with doing more community outreach, more outpatient care, creating better access of care, things of that nature. And I've seen other instances where the hospital closed and there was nothing to replace it. So, and we just had a very large hospital, 600-bed hospital close late last year. And they're trying to develop a one-stop shop campus, um, which I think will be more in line with what the community needs as it relates to social services, job creation, getting rid of that food desert, social services, childcare, maybe even apartments, outpatient medicine, pharmacy, mental health.
yeah.
Okay. A huge mental health presence there is all wrapped up into one. And, I won't mention names, but I was even, asked whether I would consider being a chief medical officer with this particular FQ8C that's going to be doing the care in this new revised campus. But getting back to your question, health systems need to take the lead
Yeah.
in developing a better presence in some of these underserved communities. And it's got to start there, to be honest, and become a little bit more culture sensitive to,
Yeah.
to not only African Americans but Latinos and others. So it's a very complex public health problem. And one thing we learned from the pandemic is healthcare inequities, healthcare disparities are alive and well. And I think it was a huge wake up call to see how that all unfolded, to be honest.
I'm amazed because the kind of clinics that stay behind when private practices and hospitals close, they're that intake desk is, well, I mean, it's not very trauma sensitive, Tim. Like it,
No, it's not. It's
know,
not. And the mental health piece is so important.
yeah,
Um, and And I just had lunch last week with a CEO from one of the FQHCs, and they're developing like a multi-level approach to mental health as it relates to urgent care, emergency room, short-term stay, long-term stay, all at one location. And I asked him, "Is that model seen anywhere else?" And it's not really been duplicated enough, where you can go somewhere and transition from one phase of care to another,
Yeah.
and you know that they're not going to be just kicked out into the
Yeah.
streets and left on their own. So I think it takes a special type of leader to say, let's take a holistic approach to
Right.
the mental health patient, where we got them not only for urgent care but short term stay as well as long term stay. And it takes a very innovative mind to say, okay, that model looks like it could work in this particular neighborhood.
Well, speaking of innovative minds, and I know this is kind of might sound like a big wind up that I've been doing so far in this interview, but you believe that part of the solution is in getting more pediatricians from these underserved communities.
Mhm.
Can you talk about your work in helping more people from underserved communities become physicians?
Well, I am the executive director of the Pathways of Practice program here at Cleveland State University. And, we have a very unique program here where our students have a direct pathway between Cleveland State University and a medical school through what they call early assurance. And if you hit two academic metrics, that being GPA and MCAT score, your spot in medical school is saved for you.
Wow.
Okay. So as I said before, have a community outreach coordinator that's out in the field talking to students who are from Cleveland Metropolitan School District, some of their STEM high schools. But we just developed a community college pathway into our program as well. And we're trying to get kids who are first generation kids, right? They may be from foster homes, they may be a
Mm,
veteran, right? These are the kids that just have not been given a fair shake at life. And there are a lot of smart kids who don't know what they don't know, right? And when you don't know how to manage yourself through these various landmines of pre medical education, it's tough.
yeah.
I come from a healthcare family and still had to figure out which landmine do I not step on. Okay.
Mm,
So we're trying to make it an easy, user friendly pathway into medical school. And our kids are going to Northeast Ohio University Medical University. And we just added Duquesne University College of Osteopathic Medicine in Pittsburgh.
wow.
And I'm proud to say we have an agreement in place with the Maryland College of Osteopathic Medicine at Morgan State University, an HBCU.
Wow.
So it's the first HBCU medical school to open up in decades, and it will be the first osteopathic HBCU to open up ever in the country. So we're proud to continue to build out these pathways where our kids will have multiple options in terms of which medical school to go to. Now, I say that only to end with this last comment, in that the average established medical school gets 5 to 7,000 applicants per year for only 150 to 200 slots. So it's very, very, very competitive. Okay. We probably need another half an hour to unpack the recent Supreme Court decision and what that means with admissions. But that's playing a role in terms of how kids are going to school as well.
Right.
But as I said, I think we need another half an hour, sir.
Well, I mean, but it's implicit in some of the things that you've said. Actually, I think my interpretation, or what I've read of other people's interpretation of that Supreme Court ruling, is that even though you're not allowed anymore, I guess, to use race as a condition of admission, you can use things that impact your performance. And
Hmm.
so, and it was actually Kavanaugh that mentioned this. So something like, we need more physicians that understand what it's like to be in foster care.
Hmm.
That could be really powerful, because you're exactly right. We absolutely do. We need more physicians that understand what it's like to live in these kind of conditions.
Hmm.
these and experience these determinants, right? So
Hmm.
maybe there's, and I'm sure that you're and you're incredibly smart, and I know that you work with smart people. I'm sure that you're going to figure that out so that we can get these communities the physicians they need. And while you're figuring it out, I want to end by letting us what would you like my listeners to do to support this effort? What can they do as individuals? How can they help you?
Well, you know what? I think that the thing that folks need to understand is we need more underrepresented minorities in medicine because we understand that compliance, access, and how you are able to be more preventive with your medical care are so important in the lives of a lot of people from these Black and brown communities. Um, I really like to say to folks that they need to understand that there's a pathway and a way that they can get there because a lot of people just feel like they don't have a chance.
Yeah.
And that's why these pathways that I just referred to are so important. That's why we have the community college pathway into our program. That's why I've added multiple medical schools on the back end as well. But we want kids to know that people that look like me as an African American are going to be here to support you from day one. In fact, we just finished an orientation with our new cohort of students that are coming in
Mm,
to start in the fall. And so we're trying to get more kids to go through our program and they get a certificate in urban health where they learn about healthcare disparities, healthcare inequalities. They get experiential learning opportunities where they do physician mentoring at the Cleveland Clinic and Metro Health. They do job shadowing at two of the largest FQHCs in the city. So the experiential learning piece is so important because, like I said, some of these kids are first generation
yeah.
college and have never stepped into a hospital before. So we're trying to give them that exposure early on in a pre-med education. But most importantly, we want them to know that there's a pathway that makes sense, regardless of the Supreme Court decision, because the guidance from that was that targeted marketing, targeted recruitment, and pathways are still permissible. You just can't use race as a
Right.
sole metric for admission. And we've always taken a holistic approach to our kids at Cleveland State University for pathways to practice.
Tim, I want to thank you so much for coming on the podcast, for sharing your insights, and for giving me another hero to look up to in this world. So thank you so much for everything that you do.
Well, I'm blessed to be in this chair, sir, and to have a more what I call a mission driven job.
Mm.
And so I leave your interview with a great sense of gratitude. I'm very blessed, sir. I wish I could take the credit. I'm just terribly blessed and humbled by the opportunity to be in this chair.
That was Timothy McKnight. More information about Tim is at talkingaboutkids.com. And when you do visit talkingaboutkids.com, please let me know what you think about the podcast. The Talking About Kids theme song is by the Senators. For more of their music, go to thesenatorsmusic.com. And remember, kids are young goats and young humans. And the difference is that young goats are easier to manage